Hi, today we will discuss a paper on 6-month parameters for the kidney prognosis prediction in ANCA-associated vasculitis. I am Safak Mirioglu from Turkey. My guests are Benoît Brilland from France. I hope the pronunciation is correct or close to correct. The senior but young author of the study, and Floyd from the United Kingdom. She is also interested in ANCA-associated vasculitis. Welcome both. Let me summarize the paper while showing the visual abstract. In this study, patients with kidney involvement of ANCA-associated vasculitis were included from 6 French centers, including main angio registry. Burden classification was used and renal risk scores were calculated. The primary outcome of the study was kidney survival. The whole cohort included 221 patients. Birmingham vasculitis activity score was quite high, and majority of the patients was positive for MPO-ANCA. Considering the 102 patients with available data at diagnosis, burden classification and renal risk score did not outperform EGFR alone at predicting end-stage kidney disease. And in 93 patients with available data at 6 months, the EGFR alone outperformed burden classification and renal risk score. Also, 6-month proteinuria level slightly improved the prediction of end-stage kidney disease, while hematuria and serological remission did not. So I think we can proceed with the questions. Lauren, do you want to start?
Great, yeah. So I just wondered whether or not you could tell us a bit more about the treatment that some of the patients received, because I guess this might have had an impact, and your study time was nearly 20 years, is that correct? So there would have been potentially a bit of variation in treatment practices during those few decades. I wondered if you could tell us more about that.
Yes. First, let me say that it's a pleasure to talk about this work. Indeed, there was a 20 years period recruitment for our patient, and so the treatment shift a bit during the recruitment period. We had approximately a quarter of patients who were treated with plasma exchange as a remission induction regimen. Nearly all patients received intravenous pulses of methylprednisolone and then were tapered with steroids. And 3/4 received cyclophosphamide, and the other quarter received rituximab in remission induction regimen. The most recently diagnosed patients were mostly treated with rituximab. It's right. Regarding the remission maintenance treatment, it was equally distributed between azathioprine and rituximab. Overall, the most recent patients received both rituximab in induction remission and in maintenance, in remission maintenance treatment. So while there was a change in practice during this 20 years recruitment period, in my knowledge, there is to date no studies that demonstrated a better kidney function nor a better kidney survival, whether comparing cyclophosphamide versus rituximab in induction or whether comparing azathioprine versus rituximab in maintenance, especially when we consider the UVAS study that were carried out on pooled recent studies. So I think that, yes, there was a treatment paradigm shift during the period of recruitment, but if it could add an impact on kidney survival, there is no data that lets us think it was a significant impact.
Thanks.
So, Benoît, you found reduced EGFR levels were the best parameter related to the kidney outcome in these patients. What was your follow-up time, and did you identify a key EGFR level to determine those patients most at risk?
First, yes, indeed, the 6 months EGFR was the best parameter related to kidney survival, and we tried to establish more complex models based on both on data gathered at diagnosis, especially considering kidney biopsies data, And we added 6 months data, notably the kidney function, but also hematuria, proteinuria, the ANCA serological remission, and those more complex models didn't add better prognosis performance to predict kidney survival. So during a follow-up of 5 years, what we identify is that there was no key eGFR value that was associated with end-stage kidney disease, but every gradual increase in eGFR was associated with a gradual increase too in the end-stage kidney disease risk. This was the same thing, of course, for the CKD stage at 6 months. So it may appear obvious for us nephrologists, but not always for all the medical community. So it's a good thing to remind it here. Every eGFR point counts, and every improvement in eGFR counts too.
Thanks.
Great. One of the other things that your paper showed was that persistence of proteinuria was associated with poorer renal survival. And with sort of new and emerging treatments, I just wondered what your thoughts were on things like starting SGLT2 inhibitors early in patients with, ANCA-associated GN, and whether or not that's something you'd consider in your practice.
Yes, this is a very good question, but before talking about SGLT2 inhibitor, I think we should go back in time a little to speak about the renin-angiotensin system inhibitor. As to date, no specific studies were carried out in ANCA-associated vasculitis patients to evaluate the beneficial effect on kidney function evolution, and nor on cardiovascular event, by the way. So I think we can all consider that the large RCTs that were carried out on CKD patients also applies to ANCA-associated vasculitis patients with CKD2. But to date, regarding RACE inhibitor in vasculitis patients with persistent proteinuria, there are no guidelines that recommend starting this treatment, whether considering the KDIGO, the American College of Rheumatology, or the European League Against Rheumatism. So there is first a point to highlight here. Then regarding the potential benefit of SGLT2 inhibitor, specific trials are on its way. I know that the UVAS group is designing some trial based on dapagliflozin at the moment, but all the data that are currently available in other glomerulonephritis, especially regarding IgA nephropathy, I think that could be beneficial to our patients regarding kidney function evolution, regarding kidney survival, regarding cardiovascular event, especially in MPO positive patients. There are also antifibrotic properties that could be of interest, and even some other properties such as steroid tolerance that could be very pertinent for patients. So this could be a good medication in addition, or maybe alone if RAS inhibitor cannot be started. But there is, however, a point of vigilance because a risk of urinary tract infection have been pointed out in the past trial. So maybe the trial specially designed for our patient would bring the light on this topic. What we know to date is that SGLT2 inhibitor use in kidney transplant recipient is fairly safe. So I think this could be used in our ANCA vasculitis patient without any serious adverse event.
So, Benoît, I want to continue with the eGFR levels at 6 months. In patients with reduced eGFR levels at 6 months, and also in addition to that, in those with persistent proteinuria at 6 months, would you consider a repeat kidney biopsy to aid further management of those patients?
Well, yes, after the nephroprotective treatment that could have an interest. The other point that we wanted to highlight is that repeat kidney biopsy could be of interest in this population. First, it's because a persistent proteinuria had a significance which could be very varying from a resistant and still active glomerulonephritis on the one hand, and in opposition, chronic kidney damage due to glomerular sclerosis, So to understand what is the main origin of this proteinuria, a repeat kidney biopsy could have the interest. There is very few studies that analyze the interest of doing repeat kidney biopsy in ANCA-associated vasculitis, and the main finding is that there is a discrepancy between the clinical impression and what is found on the histological analysis. These are similar to what is known in lupus nephritis, in which repeat kidney biopsy is more frequent, but also the patients are not the same, they are healthier and younger, so it is easier to implement in those patients, but I think it could be evaluated in all vasculitis patients. Maybe 6 months is a bit late, because if the patient is undertreated, a former time point, maybe 3 or 4 months, could be very great to evaluate the histological response, to change the immunosuppressive therapy, or in what could be do also in patients who are in fastly in remission. It could help in steroid tapering too, I guess.
Great, thanks, for answering some of those questions. I wondered whether, just moving aside from the paper, whether or not you could just tell us a little bit briefly about yourself and sort of your main interests in nephrology, the areas of interest in your sort of clinical research, and maybe some of the sort of things outside medicine as well.
Yes, so I'm a nephrologist from France, working in Angers University Hospital. My main area of interest include clinical nephrology, especially autoimmune disease and glomerulonephritis. Of course, I have a particular interest in ANCA-associated vasculitis. Now, what has driven me to clinical research was mostly the desire to translate science to patient care, I guess, and also meeting the good people at the good time, of course, made a lot. Outside of work, what I do is what I mostly like is doing landscape photography. I just arrived in Canada for my postdoc, so that will be a fantastic opportunities to develop the skill, I hope.
Yeah, that Canada is a great place to develop a skill in photography. So. And do you want to talk about the main Anjou registry and the main Anjou research group a little?
Yes, of course. So the main Anjou research group was founded in 2018 by Jean-François Augusto in Angers, by blending together the knowledge and the interest that we had in ANCA on vasculitis that fueled our project in Angers since the early 90s. Currently, we are colleagues from 4 nephrology centers in the region, and we have a growing registry that now gather more than 250 patients. We have a lot of projects ongoing, and I hope to present some of them in the upcoming Vasculitis Congress in Barcelona next year.
Lauren, do you have anything to add?
No, thanks. Thanks for talking us through your paper, and we look forward to maybe hearing about some more of your research in Barcelona.
It will be a pleasure, and thank you very much for giving us the opportunity to talk about this work.